I would like to thank the GIS board, Dr. Fawaz Mutedi, Dr. Musa Akbar, Dr. Abdullah Shihab, and all the board for inviting me for this prestigious meeting. And I would like to congratulate you for the expansion and the new programs you are arranging. And I'm looking forward to be active part of this, inshallah. Today, I'm going to share with you one case that I had, in the cath lab some years ago, just to show you that there is nothing called elective case. When you go into the cath lab at any time, you have to be well prepared. This is a 76 years old lady with typical angina for many years. She was offered coronary angiography many times, but she was always refusing and, disappearing from the clinic. She has many risk factors, including hypertension, diabetes, mainly on diet. Also, she was so difficult to take medication, dyslipidemia, and she at least quit smoking after advice. Eventually, she came back with back pain, and the surgeon had to operate on her, and the pain was agonizing. She was unable to walk. So she was sent for a pre-op evaluation. Adopitamine stress echo showed straightforward significant ischemia in both the anterior and the inferior territories. And again, after long discussion, she had no choice but do the coronary angiogram to be able to have relief from her back pain. This is the basic angio. You can see on this panel the left coronary artery. You can see there is mid-segment multiple lesions here in the tortuous artery. And in the right artery, there is mid-segment type B2 lesion. The circ was okay. So it looked like a straightforward case for double vessel PTCA and stent in the same session. That was my plan at the time I did this angio. And she was loaded, of course, she was capped, and I started by the LAD as usual. I put the wire there, and I just prepared the lesion by doing some balloon inflation in the area. And while I was changing the balloon and coming out to replace it with the stent, preparing to finish, suddenly the wire came out. I'm not sure how it came out. Did I pull it out? Sometimes in your hand is just sticky from the contrast, and you, without noticing, you get the wire out. Or it is my assistant, I don't know. But this was followed by severe screaming. The patient was screaming, I think was screaming more than the patient of Dr. Awad yesterday. Maybe you could have heard his screaming in Khartoum. She was really in agonizing pain. The ECG on the monitor showed significant ST elevation. The hemodynamic, were going down very fast. Her blood pressure dropped in no time to 70 millimeters of mercury. I realized that the wire, get out. So I assumed that the artery is closed now. So I had now the challenge of, sustaining the hemodynamics of this patient. Of course, as usual, we give some medicine, ionotropes or stuff like that, but it didn't help much. So I had to put an intra-aortic balloon pump. I forgot to tell you that her radial artery was not good. I was using the right femoral, so I removed, my guiding catheters, and I put the balloon pump through the right femoral artery. And after having help from the cardiac anesthesia, they stabilized her. They controlled her pain, and I was back in business. I tried to see what happened after the wire came out. And this is the first angio I did. And you can see here that there is an ugly looking dissection with interluminal hematoma. You can see this on this panel here. Now I have more challenges because now this was my first and last injection. I cannot inject any contrast, and I have to find the true lumen without doing any injection. I put the wire here, and you can see that obviously the wire is in the false lumen, and this was my last injection here. I tried many wires after that, I tried to take the wire back and go, I could not. So I thought maybe if I go to the right coronary artery, there might be some retrograde collaterals that can help me to find the right direction to go with the LAD. So I did an injection of the right coronary artery. I could not do double injection, unfortunately, but I tried, but the collaterals was not really very obvious. So I decided to use the double balloon technique, which is just leave the guide wire in the false lumen, and I tried with a super soft wire, the wisdom wire I used at that case, and I tried gently to go to the true lumen, and luckily I was able to find the true lumen. And I was sure about it because I was able to go to a couple of side branches, so that would have been a great help for me to know that I am in the true lumen. After a few minutes, I secured the wire. This is my injection into the right coronary, but it was not very helpful. You can see some retrograde collaterals here, but it is not very well developed. And now the wire is in a good position. I put the stent, the first stent, because the artery was tortuous and a little bit calcified, I elected to put 2 stents. So I put two stents here, one in the proximal and one in the middle segment. And you can see this is the final result here on this panel. You can see that the artery is restored in good condition and the ST came down and the hemodynamics of the patient improved immediately. It was a very impressive change of hemodynamics with this LAD. Again, this is the result. Now I can take more shots as much as I like, so I did many shots. I always do one shot in different views, like in the LEO or REO, opposite views, to make sure that there is no residual dissection or anything that I need to fix before I take the patient out. The patient did very well, and I took her back to the cath lab, from the cath lab to the ICU. Eventually, the intra-aortic balloon pump was removed the same day. And the second day, I took her back to the cath lab. I lifted the sheath in place, and I did the PTCA to the RCA, which was a straightforward case. And her cardiac enzymes, the maximum NB was 45. So thanks God, there was no big damage. We managed to open the artery very fast. This is just to show you the PTCA to the RCA, and you can see the result is quite satisfactory. So the patient did very well after that. I followed her up in the outpatient clinic, and she felt very, very well. I think she was tolerating the pain for a long time, and now she feels relieved for the first time. She did her back surgery, and she continued to follow up in the outpatient after that. So what I learned here, as always, we say when you have an elective case, be prepared for any mishaps or any complication. And if it happens, stay calm, don't panic, try to control the procedure. The first thing you have to secure the hemodynamics of the patient, use whatever you have, ionotropes, intra-aortic balloon pump, Impella, whatever the facility offers you. And if the guide wire is in place, keep it. If not, then you try to use different techniques. In my patient, I use the parallel wire technique. I just tell you some few words about it. It has been described mainly in CTO cases. It is the wire, if it is engaged in the false lumen, it hopefully seals off the entry point of the false lumen and prevent the second or the third. Sometimes even we have to go with the third wire to find the true lumen. And I was lucky that I found the true lumen here from the second wire. One thing you have to be careful when you use this technique is, you should be very gentle, not to extend the dissection plane or perforate the artery when you are doing the several attempts to find the true lumen. The operator experience, of course, the patients, you have to be very patient and take your time and be calm. are very essential for the success of such high-risk technique. Thank you so much for your attention.